For those of you watching online, please remember, if you haven't done so already, to sign in using the chat box just with your name. That way I can make sure everyone's registered for the course and I can get you your CE. If you have any questions during the event, I will be asking those for the doctor on your behalf, so please, if you have any questions, leave it in the chat feature as well. And with that, we'll get started here in just a couple of moments. Yep. Hello, everyone. Thank you for joining us in person and online. We're going to get started here. I'm here to introduce Dr. Bernstein. He's a long-term orthodontist here with a few offices in Sonoma County. He's going to give our presentation on Start with the Why, and I'll let him do his full intro. So thank you.
Okay. Well, thanks for having me. It's been a while. Same old joke, so we're gonna have to find some new ones. All right, so as I said, it's got to be 10, 15 years since we did one of those, and some stuff has changed, and some stuff stays the same. So I don't know if you guys have listened to the podcast or read the book, Simon Sinek's Start with a Why, and I figured this is a good time to start with a why, because I get asked a lot of questions every day by colleagues, dentists, orthodontists, and I get asked for advice. Now I'm kind of one of the old guys. I always think that I'm one of the new guys, but for some reason, 20 years later, you're one of the old guys, and so I'm like, oh, okay, well, let me see that. So I try and talk people through the question that they're asking me, to try and get to why. Like, why are you asking this question, which usually leads them to the answer. So try and lead people to the answer versus just giving them the answer. And so obviously, I don't know if you guys, have you listened to or read Simon Sinek? Okay, so write his name down. It's homework. You've got to listen to it, because he's way better than me. And I'm just going to give you the Cliff Notes version of that, and it's going to segue into what we're going to talk about today. But basically, he talks about how this golden circle, and he gives examples of great companies and how they use their why, both in sales, marketing, management, and how they differentiate, and the great companies and the great speakers and the great people kind of start with the why instead of starting with the what and the how, right? And so the what and the how is, and he gives an example, and I'm going to plagiarize his speech, but it's in this little TED talk, and he talks about, what do we do? What does Apple do? They sell computers. How do they make the most amazing computers? They're simple, they're beautiful, they're packaged well, blah 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 blah. But the why is different. It has nothing to do with computers. They're just going to think progressively and out of the box. And I'm probably butchering this whole concept, but it's basically you're starting with the reason why we do what we do. And same thing in dentistry. Like, why do we do what we do? And it's different for everyone, right? And different companies do this, but the great companies actually use that as a polarizing thing for a lot of what they do, instead of just focusing on how they do it and what they do, right? And so there's definitely a TED Talk, and he wrote a book. You can read the book, and it goes way more into depth about how this is not even psychology, but it's biology, and how the brain works and the layers of the brain in terms of focusing and honing in. And we've all heard of when we I heard it from consultants, but you can read about how people don't really, when you're presenting a treatment plan, people don't really want to know how much you know. They want to know how much you care, right? And they don't remember what you said, but they remember how you made them feel. And so it's the same kind of thing in trying to figure out how to be more effective, right? In your relationships, in your business, in your practice, in your day-to-day. And so I think this is a great TED Talk and a really, really good book to read. So as dentists, most of us have similar what's in house. We have chairs, and we have tools, and we have assistants, and we have hand pieces, and some of that are the what's in house, and how we do it. Well, I got trained and I went to dental school, but the why we do it is different, and maybe somewhat similar to some people. But everyone gets to tell their own story, right? And it's basically your inner purpose of what you're doing. So for me, what I wanted to do is talk a little bit about why I do things a certain way, both in my practice and just practice-wise, as well as orthodontic technically wise. And so we'll take a outside-in approach and look that way. And I'll show you where that outside-in approach comes from, and why I do certain things. A lot of this is shaped by our experiences, right? So a lot of how we go about doing what we do is just shaped by experiences, and it's formative through childhood. And I'll show you how that's really relative to, or relevant to, my story. And so then we'll talk about my story, because you have to know the story to kind of get to your why. And so Simon Sinek, if you listen to a lot of his TED Talks or his podcasts, he's really good at, when he interviews people, kind of trying to figure out what their why is. And basically what he's looking for in what you're telling him in the stories is a pattern of happiness. Like, when will you feel the happiest? And try and figure that out, of like to hone that into your job, so people can feel more accomplished and happier at work, or maybe they have to change their jobs and get to a different kind of work. So he's really good at figuring that out, and as he interviews people, but it's a process. And my story is a dental story, because it starts when I was little, right? And I was telling you guys earlier that I'm actual dental phobe. I couldn't sit in the chair. I had a lot of work that I needed to do, and they had to put me under GA to actually do the dental work. And I just couldn't sit in the chair. And one of my earliest memories is waking up in the back seat of the car, of my parents' car, driving away from probably the surgical center or wherever I did my GA to get my work done, and my mouth's like all numb, and I'm just woozy, but I'm looking out the window seeing the buildings go by. That's like actually one of my earliest memories, which is kind of weird that it's a dental memory, but it is. So I had orthodontics. I had a headgear, right? The groovy headgear back in the 70s. And I had phase 1, which is early interceptive orthodontic treatment, which was common in South Africa where I grew up, maybe not so common elsewhere. That beautiful high pull headgear gave me the reverse mohawk. And I'm in my school uniform. I'm going to school with this thing on. So talk about, not so much. Anyway, so I'll tell you a little bit, also a personal story. When I was little, and around the time that I had this headgear, you're starting school, phase 1, you're 7, 8, 9. I was one of these kids that was the last one to get picked for any sport event, right? And I sucked. I was terrible. You know, I wasn't a good, I wasn't a natural athlete, I guess, or I wasn't good at the soccer or the cricket or whatever we were picked to play. And there's always two lines of, they make two teams at PE, and they say, they get the captains and they pick teams, and I'm always the last one. And that was me. And actually, there's actually it's actually a thing where it's a psychological, it actually affects people way into their adulthood. Obviously affected me because I still talk about it, but it haunts people, this feeling of insecurity and being left out. And for me, when I look back, I realized something very, very important, that when I finished with my headgear and my teeth didn't look as bad, I didn't realize it at the time because I was a kid. But what I realized is that I started doing better in sports. I wasn't the last one being picked anymore. I was doing better in school. I got better grades. And it coincided with this finishing of this treatment, this phase 1 treatment, and the headgear that I had for years and years and years, because I wouldn't wear it. And so I had it for years and years. But that, when I look back, when I was older, I was like, that's interesting, all right? And that was that pattern that I see a lot now with our patients, all right? And so I started doing better, and so that's me. I was the vice captain of our rugby team, in high school, and I went on to play representative rugby for South Africa, and not in the main team, but a South African representative team. And again, I wasn't the best rugby player on earth, and I wasn't the best sportsman. I think the confidence just made me try harder. It just gave me the oomph to try harder. And the harder I tried, and the more I trained, and the more I studied, well, what do you think happened? The better I did. It wasn't rocket science, So I actually went to dental school, believe it or not. And that's my first day in the clinic in South Africa in dental school. And that's when I graduated from dental school. And I think this whole experience of gaining this confidence actually shaped my life and the direction that I went in, which is kind of amazing. Now, for those that don't know, but I know you guys, but there may be thousands of people online that don't know. I went to the University of Witwatersrand in South Africa, and then I went to study in Buffalo, New York, where they had more snow than South Africa. And then I didn't like the snow after my residency, and then I went to California because that was kind of more similar to South Africa. We had, palm trees and beaches, and it was a lot more fun. And so that was, 20-something years ago that I moved out. And then I came to Santa Rosa with Debbie, and I started the practice. And the first practice I started, I couldn't afford to build the office, so we rented space for a little bit. And then I rented out this little building, and Amber and Dr. Nairobi is in that building right now. And I went to visit the other day, and it actually still is holding up. But I told her, just that wall over there, if you ever remodel, just watch out for that wall, because I went in with a sledgehammer and did demolition, and the roof nearly collapsed on my head because I was trying to save some money, and at lunchtime I went in with a sledgehammer. So there's me with my sledgehammer. So somehow I have a picture of it. Don't ask me how, because there were no phones and cameras and things like that back then, but I have a picture of the sledgehammer because I couldn't get over how much they wanted to demolish all the walls inside there. So I have a sledgehammer, I can do this. And of course, the retaining wall, the roof retaining wall, the structural wall, I didn't think about that. So needless to say, I now stick in my lane. I stay with orthodontics and let the contractors do the contracting stuff. And so, my goal was always to try and remove barriers for patients so that they could get this confident smile that I got and get what I got out of my orthodontic treatment. And I've seen my orthodontist at orthodontic lectures over the years, and I always go up to him and say, thank you. Hey, this had a profound effect on me and my career and where I'm at today. So back in the day, and that first Reds lecture I gave back then, 20 years ago, was on the system that I'd seen at an orthodontic lecture, and it was called this Damon system, bioadaptive therapy, and they showed me these cases, and I was like, no no one taught me how to do this. Like, how can you can't do that. This must be Photoshop or whatever it was in the, back in the day. And so I saw these cases that they showed at some of these meetings. I'm like, we can't do that. No one taught us how to do this at dental school, orthodontic school. You know, we were pulling out teeth or doing headgears, and that was the technology at the time, and that was the thinking at the time. And people were thinking, just teeth, and this is how you move them, and this is how you straighten them. And we could do that really, really well. But these people would talk about smiles and aesthetics and faces and function. And I was like, huh, okay. This kind of rings a bell of what I was taught, but no one actually showed me how to do it. So I had to learn how to do this. So I get in my car from Santa Rosa, and I drive all the way to Reno, Nevada, because that's the closest orthodontist that doesn't feel threatened by another orthodontist that will teach you how to do this. And so I kind of jest, you know. I try to teach anyone, because, and I'll go into that later. But I happened upon Dr. Tom Pitts, who is one of my mentors and was in practice in Reno. His son is in practice now, in that practice in Reno. And I recently met his grandson, who's in orthodontic residency that I just taught a couple months ago in Las Vegas. So it's kind of cool. It's a legacy of orthodontists. And he taught me, and I went to kind of learn about how do you have a practice, you know, what does the admin, what do the front desk people do, and what do the receptionists do, and how do you run this and whatnot. And I kind of veered off into the clinic and saw all this, the clinical things that he was doing, and I was like, whoa, where does this come from? No one taught me this. So I had to go and learn it, and I would drive back and forth to Reno every few weeks to kind of look at cases and go through things. And now Dr. Pitts comes to us. You know, he's retired from clinical practice, and he comes and hangs out in Santa Rosa and teaches us and works with my team. So we've had this 20-year plus relationship, which is amazing. So one of the big things is finding mentors, right? I always think it's really important to find mentors. And I try and be a mentor for other people, which is great too, because I try and give my time to help others, right? And that's why we go into these medical type professions or dentistry, is really, in the essence, is to help other people, right? So why not help colleagues and friends? So I wanted to learn how to make better smiles, and I did, thank goodness. And I wanted to learn how to do them less invasively, more efficiently, more quickly, with, you know, just with much more consistently, and so we started doing it, and we've been doing this type of orthodontics for years. We've tweaked it a little bit, and we'll get into that a little later. But my practice grew and grew and grew, and it was phenomenal. It was thanks to a lot of support by the community and support by our patients, and I used to hear. Kids and parents are like, wow, that's a different kind of smile. That looks different to the typical straight teeth, you know. And I'm like, okay, there's more to it, yeah. And I have staff now. About half my staff or my team are former patients, which is great. When everyone went through the whole COVID thing, it was nuts. And we would reach out, and our patients came back to work for us, which is amazing. So most of my team are former patients. And, you know, so of course we want to give that back, and so I'm on a teaching team, and I go to the universities, and I do lectures, and you know, it's nice for, you know, to be on the same stage giving lectures, and this is us in November in Dallas, talking to an international group of orthodontists that do phenomenal work. I'm in awe, because of course, those of you that have taught, you actually learn so much by teaching. And so this is the practice of dentistry, or the practice, we're still practicing, we're still learning, we're still trying to get better, right? And so I, through the years, had consultants come into the office, and oftentimes we would have them also kind of talk to the Dental Society, and they spoke about teamwork and marketing, and talked about customer service and all these kinds of consultants. So we would have financial consultants and practice consultants, and they would tell you, well, as you get bigger and you're you know, you're getting more on your plate, you got to get less on your plate. And so how you get less on your plate is you got to charge more. And then less people will come. And I said, okay. And then you would work less, but you'd actually make more money. And I was like, that sounds great. I said, but that's not my why. I want to help people get confident smiles. So that's just counterintuitive the way I think, because I actually like what I do. And I like work. And I like doing it. And so that would lead to creating fewer opportunities for people of confidence. So it didn't resonate, that kind of path didn't resonate for me. And for me, the best part is the patient, my patients, my team, just having fun, creating these confident smiles. And when I get a thank you from a parent to say, hey, thanks, thank you so much, it meant the world to my daughter. Or I had a patient today, this afternoon, who we're training how to smile showing her teeth. She's never smiled, showing her teeth. And I said, your teeth are beautiful now. And I just did a little bit of recontouring as well and moving, and they're perfectly straight. And we're doing some finishing. And she says, but I don't know how. And I was like, well, that's kind of sad. Okay, we're going to teach you. Okay, I'm going to tickle you until you show your teeth. Well, not really, but I'm going to have someone else tickle you. But so these kinds of relationships, I think, are what it's about. And go back to my why, and what makes me happy is when I get someone shouts my name across the restaurant, and it's a former patient, and I'm sure it's happened to you guys too, and it happens all the time. And I think our whys are very similar. What drives us and our purposes in this field. And so again, mine comes from my headgear, but it's further than that. And so I still do this, and people ask me, wow, you have a lot of practices, you probably don't practice. I said, that's all I do. I only practice. I see patients, and that's what I really, really like to do, because I think this confidence is beautiful. I saw this picture, it's a little out of focus, but it truly is. And I think that what we have to give for our patients is truly this gift. So why would we hoard it away and say, no, you can't come, or you can't come? Well, you can, but you can't. That stuff didn't make sense to me. And so I thought, okay, let's think a little bit differently about this, and how can we continue to share this beautiful technique that I've learned and share the smiles that we want to create. Yes, we're going to have to work harder. We're going to have to work smarter. But let's make things more affordable, because remember, one of those big barriers is the affordability of everything that we do, plus other barriers. Taking out teeth a lot of times is a barrier for people that just don't want to do it. Doing jaw surgery is a barrier for people who just don't want to do jaw surgery. So can we figure out a way to help as many people as we can? Now, we can't help everyone, but we can try, right? And so one of my proudest moments is when you take braces off, patient gets the mirror out, they do the big reveal, clean up all the composite off their face, and then they look in the mirror for the first time. Some of them are crying and some are smiling, and most of them, the most common word everyone says is wow. Like, wow. Probably when you put those veneers on, Dr. Erlach, and they're like, and you hand them the mirror, it's like, wow. Probably even the temps, it's wow, right? And so I started a group practice called Wow Smiles, because that came from that interaction with our patients. And I said, well, how we're going to help more people and share this information is we're going to just have a group practice, and we're going to make that work somehow. And so now we have a group practice, and we have multiple locations. The benefit of having a group practice is a lot of benefits. First of all, it's not easy, by no means easy. But we can share our resources, right? We can share our talent. We can have buying power of the group, obviously that helps. We can offer more affordable finances. We can do a lot easier payments for our patients just because we're a larger practice. We can coordinate, we can collaborate with doctors. If I'm stuck with a case, I can ask one of my associates, just like I asked Dr. Pitts, they can ask me, and it's a back and forth collaborative effort. We pool our HR resources, right? So we have a really, really strong management system. I tried to outsource our management at some point, which was horrendous. And so I prefer having our own people, on site. I think some things are okay to outsource, but our management's not one of them. And I like having our people that have grown up in our organization that have been with us for 20 years, you know. So by doing this, you know, I was able to now make a list of the things that I like to do in my practice. Again, going back to what gives me joy. What gives me joy is to be with my patients. They go, wow, and they look at their teeth, and I teach them to smile, and not have to stay up all night doing reviews and management and HR and figure out what's the next marketing, and focus on the orthodontic part of things. And so that's what I do. And we've built a good management team that handles all the stuff that I don't like to handle, but they do it really well. They do it better than I do, and that way I get to help more people. So I get back to my why, all right? And so that's kind of just my story of the evolution of my practice, because people ask me all the time, all right? And they think that I'm sitting somewhere on a beach drinking margaritas, but I'm not. So again, there are many different ways to do orthodontics. There's many ways to practice dentistry. There's many ways to practice what we do. And if anyone ever tells you, well, this is the only way, right, I would run the other way, because there's just a lot of different ways to do things. So I'll always tell you why I do something a certain way, and give you an answer. I'll tell you what and how we do it, but I'll also tell you why we do it. But I'll never say that this is the only way. There's a lot of different ways. People, you know, associate their own practices. They part of DSOs. There's a lot of different ways to do things, and that's okay. That's okay. But I'll be brutally honest and show you why I do things the way we do things. And so again, talk about brutal. Why I am a big proponent of early treatment goes back to my sitting on the sidelines not being picked. And I didn't know why I wasn't picked. Well, I picked because I wasn't good, probably, right? Or no one liked me, or I was very shy. But that's awful. And I think nowadays it's even worse for these kids like me, the ones that don't have confidence and they're shy and they're being picked on or bullied, because all this interconnectivity online is 24/7. Just like our news is 24/7, it's overwhelming, so the stuff happens, you know, and if someone's saying something about someone's tooth or this or that or whatever, you can't leave it at school anymore. It's a 24-hour thing, and so I don't envy the kids growing up in this environment. I think it's very difficult. I think they'll probably learn how to handle it better than the adults probably, but it is brutal, and it's incessant, right? Cyberbullying and all that kind of stuff. And so I am a big proponent of early treatment and early interceptive screening. Not everyone needs braces at age 7 or 8. But again, for me, the early treatment's not really about the teeth. It's really not about the teeth. The Orthodontic Society, right, the Orthodontic Association recommends that we screen kids at age 7. We're talking earlier, Elizabeth, about impacted teeth and how we can prevent that. Most of the brochures and the things that I see are tooth-related. In terms of early treatment. Overbites, crossbites, crowdings, underbites, you know, but that's all dental. It's all inside the mouth. And I think if we take a step back and look outside the mouth, I think we can have far bigger impact on younger kids. And I'll show you where. And I think it's in the physical, just general health, physical nature for these kids, and as well as the sociological aspect of their mental health. And again, where I went to university back in South Africa, my first day, I still remember, these things that you remember, right? I guess because they're important, but these things that stick in your mind. And when I walked into dental school the first day, the dean got up and said, or the first class, sorry, not the first day. The first day they said, look left, look right, those people are not going to be there at the end. That's how brutal it was. But no, the first day we got into clinic, and they were teaching us how to diagnose a patient. And they said, don't go for the mirror, don't look in the mouth. They said, look as soon as they walk through the door. That's when you need to start collecting information about what's going on with this patient. Look at their gait, look how they walk, look how they present, look at the health history. Start assessing this information and don't go for the teeth. I know we're dentists, so we're going to go for the teeth, but look at the medication they're taking. Look at everything. Look at their face. How do they feel? Are they tired? Are they nervous? Are they this or that? So always do outside-in approach and listen. Right? It's so important. I'm not a great listener. I try and force myself and train myself to listen better. But we all need obviously to listen before we talk. And when I was in Buffalo, the main modality of treatment was called bioprogressive that we learned. It wasn't Damon, it wasn't Pitts, it wasn't all the stuff, but it was by an orthodontist from California, Dr. Bob Ricketts, who's one of the gurus of orthodontics, and he taught us the bioprogressive system, which focused on the face, right? So he didn't look at the whole body and the whole health, but at least we didn't focus on the teeth right away. We looked at the face and the function and how do these dental arches relate to that and how we're going to work with them. And it actually has a lot of similarities to the Damon system or the passive self-ligation system that we learned today. They just didn't have that kind of technology back then. But it was pretty revolutionary, talking about more than just teeth and making teeth straight. And so that really resonated with me. I got to meet Dr. Ricketts. This is not an iPhone picture. This is an old picture from when I was in school and I was young and fuzzy, but yeah, and it was it was amazing. You see one of these like gurus of our industry, and you're standing right next to them. I think Dr. Pitts is probably is one of those people too, which is kind of cool. But I think when we look for the etiology of the issue, especially with a young child, I think if we address that, like why is this malocclusion developing the way it's developing, and we just go a little bit deeper versus going straight to the cure, just like anything in medicine, if you can hit the cause, right, and hit it early, prevention's better than cure, but early intervention's better than late intervention. With any kind of disease process or or issue, or malady, whatever we want to call it, as well as the mental health issue of confidence, right, of giving these kids confidence and letting them thrive. So I think that part of early treatment is often overlooked and not appreciated enough. And so sometimes there's not a huge, big orthodontic or dental need. We look at the teeth, we look at the bite, we look at the jaw structure, looks fine, but the patient's got a couple spaces. And the patient does not open their mouth. They won't open their mouth. And the mom calls you aside and says, he's really self-conscious about his teeth. And I was like, yeah, they're okay. They'll come in, they'll be fine. But it's like, no. We're getting braces. I was like, okay, because I'm focusing on the orthodontic need and not the psychological need. And so the goal, and so I think that is really huge. I think fixing teeth is a lot. Well, we can do it at any age, right? We can fix occlusions, we can fix teeth, we can do that at any age. But with the developing brain and the developing child, with their confidence and other things, I think has a deeper impact on the long-term health of the individual. And so I oftentimes will look at the eyes of our patients, and you can really, really tell, if they're smiling. You also look at their teeth, and sometimes they won't smile. You ask them to smile, not going to happen. And so we want to create joy for our patients, right? We want them to be proud. We want them to smile. And we don't want to wait until all the baby teeth fall out to do that. There's no reason to wait for the baby teeth to fall out. And so sometimes the questions, so sometimes it doesn't come up in consultations. The moms are like, oh no, he's fine with his teeth, or she doesn't have any issues. And then if you ask, I usually ask the kids a couple of questions, and I say, how do you feel? How do you feel about your teeth? And oftentimes they'll come up and say, they're not, because you can tell that they're not smiling and they don't like their teeth. And oftentimes I'll say, has anyone said anything about your teeth? I'll just prompt that. And not to say that someone has. Most of the time it's no. But once in a while you get a kid to say, yeah, there's this kid at school who makes fun of me and blah, 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 blah. And the mom turns around and is like, oh, they've never heard that. They actually don't know. that this poor child's being, bullied or someone saying something about them. So again, we just need to listen and ask, appropriate questions. And again, look and listen. I like to look at the eyes again. I don't know why this is not advancing. Oftentimes the kids, they just won't smile. They just don't want to smile. And I think, well, you got a couple of spaces. That's okay. We like space. We like space in growing kids. And we're like, no. These kids want to smile. And the sooner the better, because I think it is just more brutal than when I was a kid, which was brutal, but I think it's worse now. I absolutely think it is. And so from the mental health standpoint and the social psychological aspect, I think early treatment sometimes is warranted. Not always, but definitely is warranted, but often overlooked. I think the growing brain now, there's a big movement in orthodontics and in dentistry, and you guys probably ask the questions that, of your patients on how are you sleeping, and sleep dentistry, and disruptive sleep. And it's been proven that disruptive sleep in these cycles really can cause adaptive changes, and sometimes if there's no adaptation, issues. And so these are other questions we should be asking at this interceptive screening. And my first slide says I'm a real big proponent about screening kids early. And again, not every kid has disruptive sleep, but we should be asking these questions using PSQs, pediatric sleep questionnaires. I got this really nice one from my friend Dr. Pobans out of Utah. And I know a lot of people take courses on sleep dentistry and breathing. And there's a spectrum. This is a slide from Dr. Zaghi, and I got their permission to use their material because it's really, really good. And they do a really, really good course on sleep dentistry and just airway assessment. And it starts when the kids are young. And I so wish more pediatricians, physicians, ENTs, laryngologists, I can't even say the word, will get on board. It'll happen. It just takes some time. But there's a spectrum. You don't start off with obstructive sleep apnea, right? It starts somewhere else, and oftentimes it's young. And so it's a cycle of dysfunction where you've got lots of different things happening. Sometimes it's skeletal, sometimes it's functional, sometimes it's myofunctional. Sometimes it's nasal, sometimes it's the back of the throat, sometimes it's the tongue. So there are a lot of things that go into airway management, but just one of those things that we really, really want to screen for in our growing population of patients. As I said, there's a lot that goes into it. And so I'm not here to talk about or teach airway, but orthodontics can really help early airway. It's been shown to really help early airway. And as I said, we want to recognize as an issue, and we ask the questions, we want to do any interceptive treatment if it's warranted, and we want to refer or we want to treat. At least start asking the questions. And I think it really, really can be impactful for just, well-being, just general well-being. And that's on our adult patients too, not just our pediatric patients. But I think because the pediatric patients are growing and their brains are developing, I think more airway is always better than less airway, right? And more oxygen. And there's, these slides is Dr. Yoon's slide of how we expand the maxilla. Remember, the maxilla is the base of the nose, and it's appropriate for certain instances to do different kinds of expansion at different ages because of where the palatal sutures are. Now again, not every narrow maxilla has a sleep issue, and not every sleep issue has a narrow maxilla. It's multifactorial. So we do all kinds of expansion as needed. So we want to really individualize our treatment plans. And then gather, if we want to go there, gather a team, because it really, really takes a team of, to manage airway. When a patient walks in, again, as the dentist and as an orthodontist, our first inclination is to look at the malocclusion, look at the crowded teeth. And my point today is look for the why. Why do they look like this? Let's look at the why. Maybe we can address the why and figure out, okay, now we can address both, right? And again, when we look at the face and we look at and ask the questions and we look, we don't only want to look from the front. We want to look from all directions when we see our patients, because we want to look and see how that mandible's growing, right? We can't really, we can't ungrow things, but we can certainly stimulate growth if we need. And these patients, we look at overbites and we're like, okay, they need an overbite. And back in the day, they gave me a headgear to pull my upper back or hope the lower jaw grew forward. And I wish, you know, I would have had the treatment that we do today. Because most class 2 patients, which is the majority of orthodontic patients, are mandibular deficient. And so we usually try not to treat the teeth, but treat the face, right? And oftentimes when you have a nice balanced face, the teeth are in a nice position too, the occlusion's in a good position too. So we use an appliance that pushes the jaw forward while the kids are growing. And so probably a lot of you guys have seen these appliances. They're annoying, they're a nuisance. Everything's a nuisance we do. Braces are a nuisance, Invisalign's a nuisance. It's all a nuisance, but we're trying to, it's a means to an end. We're trying to get to that end as predictably and efficiently as possible. And so it's funny with the Herbst protocols nowadays, we overcorrect on our Herbst patients. And I tell the parents, we're battling your DNA. A lot of times it's DNA, but it's also environmental. You know, why is this mandible so far back? And so we need to overcome that, and everything has relapse. Everything we do has relapse, right? And so nowadays we really overcorrect our Herbst patients, and we almost turn them into a class 3, an underbite. And I want to correct an underbite on a retrognathic patient. That's what I want to do at the end, is correct the underbite. So we usually leave them in and overcorrect them. So oftentimes, and the reason I'm sharing this with the Dental Society is oftentimes we get comments back, patients like, oh, the dentist said something's wrong, they have an underbite. I'm like, yeah, there's a reason, there's a why behind why we do this kind of stuff. And so we get comments, and so that's why I like to share kind of what we do and how we do it, because we want to get nice occlusions, nice smiles, and obviously beautiful, confident young people that are healthy and can go on to dental school. And I ask every single patient that's going off to college, when are you applying to dental school? And they all chuckle and laugh. But maybe one or two do, and that'll be cool, right? So that's just my standing joke. Sometimes the teeth aren't so bad. You know, the class 1, the teeth are locking in a little bit deep, they're a little bit crowded. But you know, when you look at the chin, we want that chin forward, we want the mandible forward. And so sometimes we'll extract lower teeth so that we can have more overjet to bring the lower jaw forward. Nowadays with TADS, we can drive all the lower teeth back too. We can take out the third molars, put in some retromolar pad TADS and pull the whole dental arch back and then advance it. And so do different things for different folks. Again, it's more aesthetic, and as I said, usually with the more aesthetic, the function is better, and when the function is better, the aesthetics are better. So it kind of goes hand in hand. You know, our traditional focus is teeth from the front. And so the goal, and then what I share with my residents, is always look in all different dimensions before you start making decisions on how to treat cases. Look for why does it look like this, and what's the best way to fix it. And so when we look closer and we look from the side, we can see that this will look so much better with the mandible forward. And so why don't we do that instead of taking out some teeth? And I've had a lot of patients that we've had to treat, adult patients with upper bite extractions. And I'm not saying every upper bite extraction is bad, right? Some are warranted, some needed, and sometimes I'll do it, but not when the mandible's retrognathic. We want to give them overjet to correct. You know, I like the growing kids because we can get their mandibles forward, you know, much better profile, much better occlusion, much better smile. So my daughter, I'm talking about these appliances, and we're having dinner, and she's doing this with her jaw. And I was like, what are you doing? What is this? And they're taking selfies, you know, how teenagers do. She's like, oh, I'm mewing. I was like, what is that? And so then she shows me. She says, yeah, because you look better in pictures. When the mandible's forward, you get a better angle, you get a contours of your chin-throat angle looks better. And it just looks better when your mandible's forward. And so the teenagers have picked up on this. So there was a TikTok viral video that went out about this Dr. Mew. I don't know if you guys have seen this Netflix documentary. It's called Open Wide. Sorry. Let's go forward again. Went way too far back. But anyway, and it's interesting because he's talking about pushing the mandible forward and doing myofunctional therapy to get better faces, better airways, and it seemed like this hocus pocus thing. Now, how he did it was very different to how we do it, and it took years and years and years and years and years. Not necessarily all hocus pocus. There's definitely something to it, but apparently one of the patients of this Dr. Mew put this thing out on TikTok, and it became this viral thing. So now it's called mewing, and my daughter cringes, and she's like, oh, but I asked her to mew, so that's us mewing, getting our jaw forward. So basically, mandibular advancement and tongue at the roof of the mouth, which is where it should be. All right. So myofunctional therapy, if you want to call it that. It's leaving soon, so you got to watch it. It's interesting. It's definitely interesting. Okay, and so sometimes on a patient who refuses surgery, where we want to do bisagittal split osteotomy and do mandibular advancement, we're out of ideas, so we'll do a Herbst on an adult. And I had a patient a long, long time ago that was in a car accident and just could barely function. And she found, I'll never forget her, she found a dentist up in Spokane, Washington, who did this functional appliance for her that basically brought her forward, basically a removable type of Herbst, or what we would call a sleep apnea appliance. And it made her better. But she wore it full time, right, which is what our Herbsts are. And she came to see me because she had worn it for like 5 years, and she was now like a surgical class 3 patient, like this. And you couldn't get her back. It wasn't a postured position. That's what her TMJ had adapted to, and the whole fossa had translocated on the cranial base. And I don't think her ramus had grown. She was a grown adult in her 40s, but she was happy she could function. And she had this really severe car crash. Came to see me because the low incisors were now getting proclined, and we wanted to upright them. And so we did. We uprighted a low incisor, and we left her class 3, and she was happy and functioning, and because nothing else would help her. And so airway is a huge thing. And so I started doing some research, and a lot of people use functional appliances, even on adults, and they work. They just work a little bit differently than with kids. And so oftentimes with functional appliances, because we know there's relapse, I will leave our patients in a functional position or a functional retainer to hold that position, because we know biology and genetics everything wants to go back. It's amazing how almost every sleep apnea oral appliance looks like a Herbst. Wants to bring the mandible forward. So it's got to open up the airway, because these work for people and help a lot. I wish I had a Herbst and not the headgear. I wouldn't be as retrographic as I am, and maybe I wouldn't snore as much as I do, but there's a story for another time. Anyway, so I appreciated the benefits of my orthodontic treatment. I didn't quite like the process of wearing this thing on my head, and maybe that was also kind of character building, wearing this thing. And for me, it was like cruel and unusual punishment at the time. But so when I started looking at doing interceptive treatment, there was very limited appliances. We had headgears, we had 2x4s, we had RPEs, we had Crozettes. So there were a bunch of appliances that to me were like cruel and unusual. And so I said, well, with those kids, that all we want to do is get some arch development, straighten some teeth, make them feel better. I want to come up, there wasn't anything. So we would adapt things. So when we do, arch development, let's say some expansion, not in a case that needs major airway, or in a young case, because kids under 8, actually you can do arch development with a removable appliance, with Invisalign, even with braces on all the teeth. It works great. It works just like we do for the teenagers, and it works just like we do on the adults, like Dana over here. But we glue the braces to primary teeth. And weird things happen to primary teeth when you put braces on them. And so, again, just to reiterate, not every case has an airway issue, and not every case that's narrow doesn't. So we individualize these plans. With RPEs, there's nothing wrong with RPEs, but there are some side effects with RPEs. And that's a rapid maxillary expander that's bonded in. And no one's ever told me they love wearing one. So that's for sure, no one's ever told me they love wearing one. But we do use them when we need to. But I got this from a friend of mine, Dr. DeLuke, who put together all the issues, common issues that happen with RPEs. And of course, you know, we've seen these issues with bonded lingual appliances. For me, the biggest issue is that it takes up tongue space. And we're forever trying to get the tongue to elevate. And so with anything that's on the palate, oftentimes you need to overcorrect because it's going to collapse quite a bit. And the way we do it with brackets on the teeth, we don't overcorrect. So we started doing this like years ago, and we'd do the same arch development that we did on teenagers and adults, just with the brackets and the wires. But we didn't have good attachments for baby teeth, and so the baby teeth would get loose and fall out like quickly because there were edgewise brackets on teeth. And then we tried to do eyelets because they were round. And this is just a little technical thing, but the teeth would get less loose because we weren't talking on them. You know, we had a square wire in a round type bracket. And so I designed this thing called a Bernie tube to use in combination with the wires that we use for early interceptive treatment. That is just a lot easier than putting all this stuff in the mouth for the kids, and it gets out of the way of the tongue. So the myofunctional therapists love it because they can work with the kids and there's nothing in the way of the tongue. And I think that tongue elevation is a huge thing with airway, as well as arch expansion. And so if we can get that expansion and that tongue elevating early, so that's why tongue tie is such a big deal in pediatrics for airway development. And so we have, you know, someone like Phoebe here is super crowded, narrow arches. You know, the teeth are trying to come in, there's no space, there's a traffic jam, where's everything gonna go? Oh my goodness, are we gonna take out some baby teeth? Well, you're just really borrowing from Peter to pay Paul, right? You're not making space by taking baby teeth out, you're just giving them a path. Are we gonna do some expansion, there are different kinds of fixed expansion, or we do nothing and just wait for the canines to go wherever they wanna go and destroy some teeth. I said, you know, these teeth are banging into each other, we don't want that. So we can put brackets on like we do anyone else and do some arch development. The nice thing with bracket and passive self-ligation arch development is you get expansion in the anterior, not just in the posterior. Most of fixed expansion happens in the posterior, and then you still put braces on to straighten out the teeth, or why don't you do them both at the same time? So the Bernie tubes are good for that, and they work nicely, and you can also put the space exactly where you need it. So if everything's collapsed because there's a missing primary teeth, you can open up the space so everything can erupt. And the teeth can come in. And so here's a kind of a cool morph of how the expansion happens, and it's just the same. So it's a nice system because it happens the same as we do this for teens and adults, except you've got primary teeth. So sometimes they get loose and they fall out, but which is what we want when the permanent teeth are coming in. So that's not a bad thing. Invisalign has jumped on all over this type of arch development and early treatment because it's a new avenue for them, and it's very, very similar. It's called Invisalign First, and so it's very, very. I mean, it's clear aligner therapy, but it's similar types of arch development and tooth movement as what we do with Bernie tubes. And again, everything has a pro, plus and a minus. Ooh, we can take them out, eat whatever you want, but they got to go back in. Brackets stay in, but you got to brush them. You can't eat whatever you want. So there's a balance. Everything we do is a balance. But you know, these teeth that we see all the time on 14-year-olds, 12-year-olds, 16, 19, 25-year-olds that are impacted, and now you've got root resorption, is very, very, very avoidable. I think they're very, very, very avoidable if we see the kids at the right age. And so that age 7, even 6 or 8, in that range, if we can make space and we see these teeth coming in not in the right place, we can do something about it. We don't always have to do braces. You know, sometimes all it takes is just taking out a few baby teeth. Again, if the occlusion's good, the smile looks good, the space looks good, but those canines just didn't want to go in the right place, we can direct them into the right place by just intervening just a little bit and maybe extracting some teeth. And the teeth come in, and you just leave them alone. So oftentimes this happens, and we call that driftodontics. And I had to drift those teeth into place. And so I always tell my students, how you do things in your practice, you want to do the same for everyone, right? What would you do for your kid or your sibling or what have you? That's your moral compass of how you do things, right? And so my daughter, here's my Ella, this is the one that I was mewing with earlier when she was little, and cute, she's still cute, but she was little, or littler, and so her canines are super, super high. Of course, as a good orthodontic dad, age 7, I take a pano, I look, and so I urge all the dental society, please take a pano. If you see kids, take a pano when they're young, just to look, if nothing else. And if you're unsure, share it with an orthodontist. Doesn't have to be me, but just someone. And then we look 6 months later. I said, oh, well, they're kind of high, but you know, she's got great occlusion, nice wide arches, no crowding, bite looks great, class 1. Oh, the canines don't look so nice. So we follow them. And there are a lot of patients that come to see us for the first time at this age. We just want to follow them. We just want to see. Most of them don't need a whole bunch of stuff right away. And I was like, well, yeah, I'm not liking those canines. So we took out the primary canines, and then we followed them again, and they didn't move. I was like, oh, they're not moving. They're still sitting right on the roots of those laterals, and they're not coming down. And so we took out the primary first molars. And so that encourages the first bicuspid to erupt. And boy, then they move, and then they fly down. So oftentimes now, I'll take out both the primary canine and the first primary molar if they're not moving. Right? And again, we don't want kids to unnecessarily go through, you know, invasive procedures, and extracting of baby teeth, it's not nothing, especially when they've got nice roots on them. So I send her off to the oral surgeon so she has a good experience. I can put it out of it and doesn't remember it. And so that's a good thing. And then they all come in, and that's great. And so we don't always have to do orthodontics, but I think we always should be screening these. And a lot of times it's hard, I think, for parents to understand why. Right, like, oh, I don't see the orthodontist. Still got baby teeth, right? We hear that all the time. And I said, yes, but there's so much more we can do for these kids when they're young that I think can be impactful for them. So I urge, again, all the millions out there that are listening to to refer early, at least to an orthodontist, to take a look. Again, here's my other daughter. First day she got her braces on, and again, same thing. I do the same. She had phase 1 and phase 2 because that's what she needed, you know. So, and she had the Pitts brackets and Bernie braces and the same protocol as everyone else. Again, I love doing early treatment with brackets and wires because I can put the space exactly where I need it. Oftentimes, if you see like Dwight over here, missing that lower left C, the lower left primary canine. Lower teeth don't look super crowded, but they're all shifted over to where that space is. And so we can take out the other canine, but again, you're not making space, you're just kind of evening it out. I like to actually just regain the space and then retain it, wait for the teeth to come in. So super easy to do. Again, we don't want to go for too long in these treatments, especially with these young kids. If they're little class 3, we can run rubber bands now. The Bernie tubes come with hooks for this, so we can have our same systems on correcting class 3s. Class 3s, I like to rotate the occlusal plane because usually they have a very, very flat occlusal plane, and so the earlier I do it, hopefully they'll grow with that occlusal plane and not grow in that uncontrolled, horizontal vector. And these correct quickly. These kids, it's amazing how quickly they correct. We don't want to drag on these treatments. And then we follow these kids. We follow them every 6 to 8 months. We look, see how they're growing. Again, what I've seen over this 20-year, well, I've been doing it for 25 years, but in my practice, is the true skeletal class 3s, like the ones that are like true surgical type cases, oftentimes outgrow what we do for them early. They just oftentimes outgrow. So we try, of course. We always try, but we're always in the back of the mind to tell the parents, the genetics are strong in a class 3. That jaw wants to grow. So we'll have to wait and see. And oftentimes you can look at the parents, right? Take a step back and look at the parents, and you kind of know how these kids are going to grow. The nice thing about correcting class 3 this way with brackets is I can set those upper incisors vertically in the face. And so usually with those very brachyfacial class 3 patients that have a flat occlusal plane, you don't see a lot of upper incisor. And so I can start working on the aesthetics early, and we can see more upper incisor after that correction. And that's just partial correction. We can do more when he's older in phase 2 if we want. So I like doing the aesthetics and getting the aesthetics underway in class, or I should call the macro aesthetics early in class 1. Cross bites unilaterally, easy to correct. A lot of times this is just a narrow arch that just needs some expansion, and these kids come out of these cross bites really easy. Oftentimes you just need upper braces and the wires, and again, we don't have to overcorrect, but we get all the space we need. Oftentimes I'll tuck in the laterals, so because the canines are coming down, so we'll tuck those in, let all the teeth erupt. And they're very, very stable. They wear retainers at night. All our patients, we ask them to wear retainers at night only, because I lost about 6 retainers, and I don't want anyone to lose a retainer. So when I was a kid, so let's not do that. And so sometimes they grow out of the retainers and everything stays nice. The overjet patients, again, this is huge risk. I know pediatric dental friends of mine always tell me, as soon as the sun comes out and summer happens all weekend long, the kids are on bicycles and skateboards and scooters, and those front teeth are the first things that they hit. And so oftentimes when we see a kid with a large overjet, some proclination, there's always a filling on one of those front teeth because it's already happened. And so getting those braces on and uprighting those teeth and retracting them into a better position, very easy, very simple thing to do. If a patient's super retrognathic, I will even retain them with kind of like a sleep apnea appliance, a removable Herbst or a twin block, very similar type of appliance, to get them growing in the right direction. And so get those upper front teeth out of harm's way. Very, very predictable. I like braces to do this versus aligners. It's just more predictable in my hands. But as I said in the beginning, there are lots of different ways to do orthodontics. But we want to see these kids early and get them growing and functionally well, get them smiling, and very, very important with open bites is the myofunctional side of things. Getting the offensive, whatever it is, out of the way and getting them swallowing properly. Okay, so goals for phase 1 are physical health, mental health. Again, dental health is also important. It's not that it's not important. We want optimal facial growth, and then we're trying to avoid future invasive treatment. Right? That's one of the things, and just balance the function in the mouth. So balance of where the teeth are in the arch between the cheeks, the lips, and the tongue. We want to keep early treatment short and sweet. We don't want to drag it on for years and years because patients burn out, right? Hygiene, oftentimes, these kids struggle with, and especially putting braces in their mouth. We always tell the parents, we're going to want you to brush their teeth, because that's what I did with my daughter when she had her phase 1, and I sat there and, well, she's too old for that. No, she's not. It's hard for the kids to do that, and I equate it like at night. She can do the morning and after school, but at night before she goes to bed, I want you to brush her teeth for her, and this is how we do it. And it's going to be like you telling her a bedtime story, like when you were little. It's like a nice connection thing with the parents, and so a lot of the parents will do that. And it helps, because, again, hygiene is always an issue. Anytime you glue anything in the mouth, right? Whether it's a crown or a brace or anything, hygiene is always an issue. And then oftentimes, because we're doing the aesthetics, the teeth come in, we're making space, oftentimes the second phase is optional, which is fine, which is great. Parents are celebrating, kids are sad they don't get braces again. But that's okay, you know. And again, I go against the consultants in orthodontics who say, well, don't retain phase 1 because then you're not going to do a phase 2. And I'm like, okay, for me that's success. There's plenty of people that need our help. It's okay if a good portion of our phase 1s don't need phase 2 or don't want phase 2. That's okay. You know, that's okay too. So I kind of go against some of those consultants about retention of phase 1. I like to retain phase 1. Okay, how's our timing going? I got about 4 minutes left. I have 4 minutes. 5-0. I better start talking slowly. Any questions, like any about this stuff? Again, a lot of what we do hasn't changed. It's just a little bit different. We're using a little bit different tools. You know, the techniques and the appliances have changed a little bit, and I'll talk a little bit about that, because I figured we'd get technical, show some teeth. And it's not all about faces and whatnot. But funny, when I saw this initial Damon case at this talk, and then I had a patient walk in who had the exact same teeth, and she was an adult, and I was like, oh my goodness, how are we going to do this? And guess what? We can do this, and it actually works out, and it's stable. And so for years and years we used the system, and it worked really, really well to do arch development, make space for the teeth. And again, people will say, hey, this is not stable, or you can't do this, and blah, blah, blah. The teeth are going to fall out, and it works really well, and it's efficient, and we still are using the same system 20 years later. And now, because I'm old, I get to see these kids that are now grown-ups, and they bring their kids. And I get to, you know, they go off to college, and I see them 10 years afterwards, and they come back, oh, I need a new retainer, or I need something. And it's kind of cool. You know, I guess being an old guy, you get to see this kind of stuff, and so I get to look at their teeth and how's it going, and it's kind of fun. Challenging kind of the old dogma, or I guess the old ways, really opened my eyes to being able to look for solutions for our patients, right? Where they would say, no, you can't do this, or you have to do that. And I was like, well, the patient doesn't want to do that. Can I do this the way they want to do it? And it really was impactful for how we practiced. And you know, again, it's about the relationships. And I see this guy at Home Depot shouts across Home Depot one day. He's like, "Hey, Dr. Wu, how's it going?" And he's smiling ear to ear, you know. And that's really what it's about. That's the why. You know, those relationships and those moments are awesome. Or Yali over here, who was told she needed jaw surgery, and she needed all this kind of stuff to correct what she had going. And funny, I had the story with Yali is there was someone who worked in my office. Yali worked at an orthodontic office, and the traditional way to correct this is jaw surgery and yada yada yada. But the person who had gone to work in that office had told her, listen, I know you don't want to do jaw surgery. Why don't you go and talk to Dr. Bernstein? And so she came for a consultation, and I said, yes, traditionally, ideally, we want to get the jaw bones in the right place, but we've done this before, and we can help you as long as you do this, this, and this. You know, we can correct what you need corrected. And then she disappeared. And so a few years later, she's working for us. Okay, and she's like, okay, I'm ready to put the braces on and start wearing my rubber bands. And I was like, oh, I had to go back to my charts and look. I thought, but I saw you a few years ago. And so she actually came up to work for us, and we did her treatment. And she was an expert. You know, she wore her rubber bands like crazy, and she brushed her teeth, and she kept everything wonderful. and her bite and her smile looks fantastic. So the dental alveolus is actually plastic, and we can move it a certain amount carefully. And we do it carefully, and there's a way to do it. And so we started using this Damon system for years and years, and we switched. At some point, there were issues with the company that we were using and how they were producing the brackets, and the precision wasn't quite where we wanted it to be. And so now all of a sudden, the end result, we're spending a lot of time trying to straighten these teeth because the precision in the brackets wasn't where it needed to be. And so Dr. Pitts, who's my mentor, said, no, Rael, it's not you. You haven't forgotten how to put braces on. It's actually the bracket. We started looking at it, and he left. There's a whole story behind that. And he went to the company, like a German precision manufacturing company in Oregon, who made then now our bracket, which is the Pitts 21 brackets that we still use. So it's made in, we know where it's made. I visit the facility. I know what they use and how they use it, and the tolerances are unbelievable. It's like German engineering in orthodontics. It's amazing. And so, back in the day, we would measure these cephs and the angles of things, and that's great to kind of know where you're trying to go. But oftentimes, we're trying to fix an occlusion, but the smile doesn't look good because we're having to do things to fix an occlusion, and the smile doesn't look quite right. And they do research papers on this, and they say, the ABO, the American Board of Orthodontics, there's a very weak relationship between the board scores and the aesthetic scores. And we're like, I thought straight teeth were aesthetic. And we're like, not always. And we're just trying to delve into that a little bit more. But aesthetics is a huge big deal, right? Again, for me, the confidence of having an aesthetic smile, but this has been researched to death in the aesthetic cosmetic surgery industry, in the aesthetic dentistry industry. We all kind of know in our culture, in our society, that this is important. Maybe not in everywhere in the world, but for us, for sure. And again, it's now shared bazillion times a day. Those selfies are not taking pictures of our feet, they're taking pictures of our faces and our smiles. And so, and again, I guess it's all perspective, but I think back when those shows on TV, the Swan, or I don't know if you guys remember those makeover shows on TV, and they would always interview the person who had this transformation, and they would have cosmetic surgery, and they would exercise and diet, and they would have their dental work done. And of course, us as dentists always picking on the dentistry, But we take a step back and we ask them, what was the biggest transformation? And by far the majority would say their smile, which was hugely impactful, because they changed head to toe. They had changed, but a lot of them would say my smile. And we're picking on the dentistry, but again, step back. When you look at a lot of the aesthetic industry, it's all about perspective, right? I bet you the optometrists are looking at the eyes, and the cosmetologists are looking at the makeup. Again, everything's perspective, but those were not dentists, the interviewees, right? They were just saying what was the biggest transformation, and they themselves would say their smile, because a lot of them had obviously a lot of dental issues. Anyway, so Dr. Pitts, whose bracket system we use, as I said, from way back in the day, is really focused on aesthetics, all right? And so it's called the Pitts Aesthetic Discipline, and there's a lot that goes into it, and very, very similar to aesthetic dentistry, right? When you look at the macroscopic, the microscopic, the mini, aesthetic parameters that we're looking for a patient. And so we look at the same stuff, right? And so for us, there's certain things that we have the tools in our tool bag that we can affect, which is obviously the smile width, the smile arc, the upper incisor position, the lip frame, and we can try and do this as naturally as possible with the natural teeth, and then come into looking at pink and white tissue. So for me, it's pink and white. Are we plus, even, or minus, right? Are we adding or are we taking away? And are we contouring? Well, what does it look like? What do the emergence profiles look like in the embrasures? These kinds of things that I know is your language, Dr. Erlach, all day, every day. Can we do this efficiently and quickly and aesthetically? And so Dr. Sarver is one of our main or big teachers in orthodontics, a big name in orthodontics, came up with the outside-in approach. And look at the macroscopic first, macro aesthetics first, then go into the mini aesthetics, and then really look at the micro aesthetics. So, face, lip frame, teeth themselves. We same thing, outside-in approach. Let's look from the outside. So smile width. We have now these really, really big wires now that go with our system to really fill the negative space in the smile, right, in the buccal corridors. And our wires now, we have extra broad wires with this PIT system to really, if we need to, fill that space. And one of the things that we do when you look at our patients as they're going through treatment is we want to sit them up and look face to face. Because most of the time we're looking at a patient from the side and they're laying down and we're missing the big picture. So we want to sit them up, and so we typically do. We'll take pictures sitting up. We'll take pictures at every appointment for our patients and then look at that smile picture and also look at the patient before they lay down to see, do they need more width, right? And again, everything's a balance. Can the tissue kind of handle that width? Can it handle that pressure? Where can we go in this neutral zone between the tongue and the cheek? But if we go slowly and gently over time, it can adapt. So we definitely can affect the smile width. We also look at the curvature of the smile, or what we call the smile arc. A lot of times in orthodontics, we're trying to fix an overbite or a deep bite. And so we'll position brackets to intrude the upper incisors, not thinking that, hey, this is going to flatten off the smile. And so one of the things that we do is we were very adamant about is developing the smile arc. And so we'll set brackets really, really high on the teeth if we're really trying to develop a nice smile arc, which is contrary to traditional bracket placement. Again, just like talking about Herbst or anything else, oftentimes we'll put the brackets up high because we're trying to achieve a certain thing out of the aesthetics. And then we'll get comments and patients will say, well, my friend said my brackets are on wrong or something. I was like, well, when the friend goes to orthodontic school, they can come and talk to me. But in jest, so there is a reason, and you'll see not just with the PIT system, but with any system, even with Invisalign, a lot of the orthodontists are trying to develop smile arc and not trying to set brackets or set those upper incisors to correct the malocclusion. We try and fix the malocclusion elsewhere. But the upper incisor is such an important tooth in setting the smile. And so, oftentimes it's like, oh, those brackets are in a funny position. So we actually made posters in our office to tell patients this is going to happen. We're going to put these brackets up here for this reason. And so traditionally, we would put brackets pretty incisal when you're trying to open a bite. Even if we're trying to open a deep bite, if those upper incisors are in the right place, we don't want to move them. We're going to open the bite by maybe extruding the molars, but not by intruding the upper incisor. Again, we want the edges of the teeth to follow the contour of the lower lip. That's the smile arc, right? And so we set our brackets pretty high to do that. Sometimes they're right on the gums. Now, if the patient's not doing a great job with hygiene, we may have to move it and forfeit a little bit on that smile arc. But, again, everything's a balance. Everything's a balance that we do. And so we want nice looking teeth, nice smile arcs, youthful smiles. And so bracket placement is determined by the aesthetic goal, not the occlusal goal. Does that make sense? So this is Dr. Sarver, and he had a statement. He said, "Don't make a kid ugly to get a good occlusion," right? And he's the guru of aesthetic orthodontics. I mean, he's amazing. And he practices out in Alabama, of all places. So I got a transfer case to my office, got nice high-tech brackets, self-ligating, fancy, expensive, and then I looked at the pictures, and so, again, power of taking pictures and looking at them is you see things. I can see that bracket placement without taking the picture of where those upper incisors are going to be. And of course, they need to be repositioned and whatnot. So just saying that I use the technology, that doesn't always help. Putting the brackets up high like that also helps us tip that occlusal plane. So if we want to, because about an 8-degree occlusal plane from Frankfurt horizontal is seem to be ideal in terms of aesthetics, and not just smile arc left to right, but back to front. You want that smile arc. So we tip the occlusal plane. We use bite turbos a lot of times to disarticulate and move the occlusal plane. And so oftentimes you'll see those little, in our office we use a blue glass ionomer, see this blue stuff on the teeth, and it shouldn't be a glob, just so we don't bite the brackets off. That's not what bite disarticulating turbos are for. They're actually, we call them strategic disarticulation, because we use them strategically to either move the occlusal plane or get an asymmetry out. We did one today where we've got an occlusal cant, we've got a smile cant, and so we're going to intrude one side and extrude the other. So we want to use those strategically. And so for different kinds of cases or occlusal correction, we'll put them in the front, on the back, on the sides, all different types of places. And so again, that dominance of the incisors and that uprightness of the incisors is really, really important. And passive self-ligation, which is typically a non-extraction type philosophy, oftentimes would leave incisors proclined and got a bad rap. No, you've got to pull teeth out. You've got to pull teeth out, because otherwise the teeth are going to procline when there's crowding, because that's the path of least resistance, right? The teeth is just going to go forward. And so we now have custom torques on our brackets, and oftentimes we'll flip our brackets upside down, especially in the incisors. And I would say about 50% of the time I flip the brackets upside down in the upper incisors, and the reason I do that is to keep the upper incisors upright, because upper incisor brackets have a specific amount of buccal crown torque, and we want to keep it upright. We want lingual crown torque or no crown torque. We don't want that side effect of the teeth proclining. So we'll flip them upside down. Again, it's nice when you have doors on the brackets, because you know they're flipped. With traditional brackets, hard to tell if they're flipped or not, because there's no door. Which way is the door going? So I like passive self-ligation just for that. And so oftentimes we'll get those brackets up nice and high and flip them to keep the up incisor, that dominant tooth, upright, because we like that perpendicular to Frankfurt, also perpendicular to that facial plane. They say about 0 or 5 degrees is the most aesthetic position for the upper incisor, and we don't want, it's not a great look. Again, sometimes if patients are non-compliant, they're not doing what they need to do with their rubber bands, teeth start to flare. Sometimes we have to really disc them a lot, or we have to extract teeth, But again, we have to assess each case as we treat them. But the goal is to have the most aesthetic looking set of teeth for everyone. And so that 5%, 0 to 5 degrees is what they say. And then that's in natural head posture. Again, head posture plays a huge role in how we assess a patient and how we look at them. So we really want to try and get them into natural head posture. There you go. And we try and do it as naturally as possible. If we have to do little cosmetic contours, I use some composite. We do a lot of composite bonding nowadays. It's just easier with the patients there. And I always tell them this is temporary. You need to go to your dentist and get the real ones done. But it gives us a good kind of indication of where these teeth and where the gums need to be. If I need to take out the laser and contour the tissue, we do that. I did an upper canine to canine today. It was fun, because it's for us in orthodontics, composite bonding and tissue contouring is instant. Everything we do takes years, but when we can do like an aesthetic thing that's instant, it's like, wow, we get all excited about it, because it's instant, and very little that we do is instant. So we get all excited about it. A lot of things obviously go into aesthetics, but these are some of the newer techniques that we're using, like the flipping of the brackets and using square wires now to get optimal aesthetics for our patients, because I think that's important to them. Now, the other kind of lead on to this is knowing obviously where those teeth need to be in the face, and not just for now, but also for the future. So when we're treating a 12, 14-year-old, okay, how's this face going to age? Right? What are we going to do now to help this face age well and the smile age well? And so we know certain things about aging that are pretty common, and we know that upper lip is going to get thin. We know that as you get older, we're going to show more lower tooth than upper tooth. If you look at actors from back in the day, and then you look at them now when they're interviewed or when they're on screen, you always see more lower tooth than upper tooth. It's just how the face develops. The whole thing droops down. And so I tend to like to have the teenagers and the kids finish a little bit more gummy, right? Because I know that face is going to develop differently. But the face changes from 18 to 25 and changes from 25 to 45. So there's changes happening all the time, and so we're trying with setting our brackets and finishing our smiles to take into consideration, you know, the aging process. The support of the upper lip, we know those upper lips are going to get thinner, but in different populations, they also react differently, you know. So factoring that into the treatment plans is important. But understanding aging, you know, face doesn't stay, unfortunately, the same way. That goes back to when I tell patients about retention and retainers, and I say, you know, nothing stays the same, right? Your body's going to change. As we get older, everything changes, right? And I wish I had like a full body retainer, right? Like a pair of pajamas I could wear every night, and it would keep me in the same shape that I was when I was 18. Wouldn't that be nice, right? But well, I don't really have that yet, but I have these retainers that you can wear, and if you wear them, maybe not every night down the road, but once in a while you'll try them on in years to come, make sure that they fit. It means your teeth are nice and stable, they're staying where they're staying. And everyone gets a chuckle out of that. But that, you know, aging happens, unfortunately. And I don't know, there's biohackers now trying to kind of not age. So that's a whole other discussion. And as I said, you know, orthodontics is kind of like a pile of rocks. I saw this at a meeting one time, and I got the slides because I thought it was really, really clever in how we're juggling our patients and all these needs. You know, the patient's desires. What do the patient want? Right? What do we want? What does the occlusion want? What does the aesthetics want? What do the tissue and the joints handle? You know, like all these things. I want to run rubber bands, but patients got some joint issues. All these things we're juggling all the time, and what we're trying to do is make the best outcome juggling and balancing all these different aspects. And that's what we do in our practices with our patients. I can't open that wide, so how am I going to get to that second molar? You know, so it's not always, you know, cut and dry typodont what we do. But we do want to make sure that we pay attention to the aesthetics. I think that's a really important aspect of orthodontics. Occlusion, of course, a functional occlusion, important. That goes without say, you know. But I think a lot of times we, as orthodontics, sometimes can wreck the aesthetics by trying to fix the occlusion. And there are different ways to do that, and that's why I really like this PITS discipline, because it really, really has protocols for the different types of malocclusions to deliver optimal aesthetics for all the different types of malocclusions. Right? Class 2s oftentimes have decent incisor show, right? Because they don't have an incisal stop at the lower incisors, right? But oftentimes they're crowded and their bites are deep, so we have to fix it a different way. But oftentimes class 3s are very flat. The occlusal planes are very flat. So how do we tip that and get an optimal aesthetic result out of that? And so, you know, we get our brackets up and we wear the rubber bands. And again, can we do this in a timely manner where we don't burn the patient out, so they can comply and get things done? And we don't have to tell them they have to have teeth pulled and go to surgeries and all these kinds of things. No one likes to hear that. Sometimes they do, and we do surgical cases all the time. But not on every patient, right? The class 3 protocols, I did this little animation because I do teach the system, and it really, it took me years to understand how we were correcting these malocclusions, because I thought we were just going backwards and forwards with class 3 underbite. And actually what we're doing is we're rotating the mandible. So we're rotating the mandible down to give us space to bring the upper incisors down, so we get more upper incisor show, right? And when you rotate the mandible down, it goes into a more retruded position, right? It goes into a more class 2, it's called a class 2 rotation. And so you make in the class 3, class 2, which ends up being class 1, which is nice, but you get better incisal show than just going back and forth. And it's not a dental compensation, because we used to maybe take out some teeth on the bottom and then tuck the lower incisors back, and then they would lean back. The upper incisors would lean out, and it doesn't look nice, right? We want those upper incisors nice and upright, even though there's crowding, even though the patient's class 3, we want a nice functional occlusion too. So just paying attention to the aesthetics, I think the PITS discipline does a good job of having protocols to offset the side effects that we sometimes have with fixing malocclusions. And getting those beautiful, big, wide, wow results, which is what it's all about. So again, that's my how and my what. Like how do I do this? What do I do? And it helps me get to the why, which is those beautiful smiles. And the only constant is change, as we know. So probably in 10 years' time, I'll be giving a different lecture. It's like, okay, all that stuff that we did, we're doing this now. And hopefully there'll be a good, intelligent why we're doing it. But thank you. I really appreciate you guys being here and listening to me talk about kind of why I do what I do, and share my story. I get a lot of kind of young practitioners ask me stories and like, oh, how do you do this, or how do you do that, or why do you do that? And so I just want to make them think, right? And just teach them critical thinking of start with start from, just like we assess a patient, start from the outside. Like start with the big picture versus trying to fix the little things, and focusing on the little activities. And think about the strategy, right? So strategy first, and activity second, and then think, why are we doing this, or why do I need this, and so hopefully help them. And that's kind of how I force myself to start thinking, because I also have the tendency to jump to, okay, we're going to fix this and do that. I'm like, okay, why is this happening? Let's figure this out. Let's take a step back. Let's breathe. We're all in our practices every day. We're in quick thinking brain, right? We're doing this and seeing that patient and fixing that and going to that patient, doing that exam, and we're in quick thinking mode. And sometimes, more important questions need slow thinking. We need to be in a slow thinking mindset. So sometimes we just have to get out of that situation to come up with answers. So, anyway, hopefully my little story and my little spiel helps some people out there in the cyber world, and those of you kind enough to come tonight. And again, with all of this, there's no wrong answers, right? They're just different ways of doing things. And so I have tons of books. People ask me about books of what can I read and how do I get the information. And I love to read and listen to podcasts. And I guess I'm a dental nerd. This stuff excites me, and I enjoy it. And that's why I keep doing it. And hopefully I'll be healthy enough to keep doing it. And that's it. Cool. Thank you.
I do have a question.
Yes, sure.
When you're going from a class 3 and
Uh-huh.
then you're going to a class 1 by lowering the jaw,
Correct.
do you take care of the curve of spee at all in the posterior? Do you know
Correct.
what I mean by curve of
Well,
spee?
you almost want more curve of spee, because typically a class 3 has very flat curve of spee. So you're actually building in curve of spee with this bracket positioning. Remember, I call it the wedge bracket positioning. The brackets are moving away to actually create a curve of spee. Because on class 3s, you've got just a very flat curve of spee. Did that answer your question? Yeah, okay. I don't know if there's any questions. Any other questions, Matt? Are there any other questions? Okay. Good stuff. Excellent. So I can switch this off. Well, thanks, you guys.
Thank you to everyone watching online. Again, I will be sending out the CEs for our online participants tomorrow. You should be receiving them via fax or email. If anyone has any questions, feel free to reach out to the office, 707-546-7275. Again, thank you, and I'd also like to thank Dr. Bernstein for coming in to give the CE this evening. Thank you, and have a good night.